Hi, I'm Dr. Stacey Fox-Alvarez. I'm a medical oncology resident at the University of Florida, and today we're going to be going through a case together. So this is a clinical case, and it's going to involve managing a patient with a mast cell tumor. Although you guys already know that this is a mast cell tumor because it says so on the topic of this presentation, and because I'm telling you now, I really want you to work through this case in your mind like you are seeing it without having that information. So I want you to take into account all of the patient factors and the history information to come up with a plan for this patient and sort of forget that this patient has a mast cell tumor and start with more of an open mind. Okay, so this is Bluebell McTavish. She's a new patient to you. You're working at a general practice hospital as a general practitioner. And I want you to imagine that you're working in a hospital that's large, but it doesn't have any specialty services. So you don't have a CT, you don't have an MRI, but you have digital radiographs, you have blood work, and you have a point of care ultrasound machine that's available to you. So I want you to kind of get in that mindset when thinking about her case. So this patient just moved from South Florida to Central Florida. She's an 8-year-old female spayed pit bull, and you've never seen her before. And she's presenting as a walk-in patient for increased breathing, sounds, and effort. The owner notices that this is exacerbated when she's excited. She also has a 3-day history of soft stool that's intermittently diarrhea. She's had 2 episodes of vomiting. And she's not really eating her normal dog food well. She's lip smacking and salivating. But the owner can entice her to eat a little bit less than normal if he mixes chicken in with her food or feeds her just chicken and rice. Initially, your nurse brings her back into the treatment area, and you notice these 2 red masses that are adjacent to her right eye. They're erythematous and alopecic. You try to palpate to see if they're painful, and it's hard to tell because she's really excited. And when you touch her face, she kind of shies away, but she's really, really wiggly. She also has a mildly elevated temperature at 103.5, and her face, as you can kind of appreciate in this picture, seems a little bit swollen. All right. So I'd like you to formulate a broad categorical list of differentials for these masses, and you can use DAMIT-V or the Chang scheme, or if you have another acronym that you like to use, go for it. Once you have your broad list of differentials and your categories written out, I want you to expand whatever your neoplasia category is to include all of the cancerous diseases that you think would be able to cause a dermal mass like this. So take a minute, write down your answers, and once you've really thoroughly considered everything and written everything down, you can move forward with the video. Okay, so I'm going to go through the broad differentials list for these masses. I'm going to start with Chang. So Chang is an acronym that stands for cyst, hematoma, abscess, neoplasia, and granuloma. And this is just a quick list to keep on hand for anything causing a dermal or a subcutaneous mass. It's not comprehensive, but it's just a way to remember the most likely causes as you're rolling things in and out. And then here's the DAMIT-V scheme. So degenerative, anomalous, metabolic, neoplasia, nutritional, infectious, inflammatory, idiopathic, traumatic, and vascular. So although we don't know a lot about Bluebell's case yet, I just want to go through these quickly and already be able to hopefully roll some things out. So based on how these masses feel, although they're non-painful, you are able to feel them in, let's say they feel firm. So based on this, I would say a cyst is probably unlikely because that's going to feel like it has fluid in it. A hematoma usually looks more red or bruised, and so we can say that's probably less likely. An abscess, neoplasia, or granuloma are definitely still on the list for Bluebell. For degenerative disease, again, this is unlikely given this presentation. Anomalous, which is another word for congenital, unlikely. Metabolic, I'm going to leave on the list because we know that some metabolic diseases can cause cutaneous abnormalities. Neoplasia is certainly still on the list. Nutritional, I think less likely. Infectious, inflammatory, those are both included. I ruled out idiopathic, or I crossed out idiopathic, because although we can't really say that it's not idiopathic, there's not a known idiopathic syndrome that causes these, characteristic dermal masses. And we haven't ruled everything else yet out. And then traumatic is still on the list. Vascular, I would say that this, in this circumstance, would be kind of synonymous with hematoma, so unlikely. Okay, so let's continue with our physical exam of Bluebell. Just take a second and look at these photos, and then I'll point out what we found. So one, she obviously has a really large subcutaneous to deep mass that's extending from her ventral mandibular, ventral cervical area. It looks like it's predominantly right-sided, but you can see from different angles, this mass is causing a mass effect on several different planes. So it's causing kind of a double bubble sort of mass right here. You can see it extending down to her ventral cervical area. And then on her other side, from her left side, she doesn't look like her face is as affected on this side, but you can still see that mass effect extending in the ventral cervical area. I also want to point out that this Sharpie line is actually highlighting the palpable extent of the mass. So it goes a lot farther than what is obvious based on just what's going on with her skin. Okay, so she has a large firm swelling facing her submandibular area. It seems to be spanning from the right to the left side and extending down towards the thoracic inlet. It's softer and kind of edematous around the margins, and it's really difficult to distinguish individual structures within this swelling. So you can't find lymph nodes, you can't find the salivary glands, it's just all coalescing and firm. She has stridor, and it's definitely more noticeable whenever she's really excited and breathing faster. You estimate that she's about 5% dehydrated. She has normal heart and lung sounds, and her abdomen feels normal. And you do not appreciate any other masses or lymphadenopathy. Also on rectal exam, she has soft brown stool. So now that you have completed your physical exam, what questions do you want to ask the client? And I just want to point out that the rest of the information is pertinent here. So initially looking at her with those red masses and facial swelling, you might be suspicious of something like an allergic reaction from an insect envenomation. But feeling the rest of that swelling underneath her ventral mandibular area, it may have changed your differentials list a little bit. So just think about what information you want to make sure you get from the client in your history. Take a second and write down your answers. You don't need to use complete sentences. You can use kind of bullet points for the data that you want to get. That's totally fine. And then when you have a good list, you can resume the video. All right. So this is Bluebell's owner, Mustache Mark McTavish. From him, you learn the following information. So she hasn't had any new foods or treats in the past month. She only takes fish oil daily, 1 capsule twice a day, and she's been on this for a long time. She's not on any other medications. She has no prior history of illness. She has no known trauma or penetrating injury to the oral cavity or face, and she's not a dog that really likes to chew on bones or sticks. The owner also mentions that he walks her outside on a leash, and she doesn't have any unsupervised access to the yard. So he feels like it's unlikely she could have gotten into anything that he would not have known about. She is in Central Florida now. She came from South Florida, and she has no travel history outside of the state of Florida. The owner did mention when you ask about the mass by her eye that she had surgery about 5 months ago for a mass in that location, but that it grew back about 1 month after surgery, and it's just been getting kind of slowly bigger since that happened about 4 months ago. He's noticed that the cervical swelling started about 7 days ago, but it's become more pronounced over about the past 2 to 3 days. And as it's gotten bigger, her breathing changes have started. Okay, so you want to know more about the mass that was removed. And the owner says that it was there for about 3 weeks before the first surgery, and it came up out of nowhere. It was a little bit smaller than it is right now when the previous doctor took it off. You want to know if it got sent for analysis or if an aspirate was taken before surgery to get a diagnosis. And the owner says he doesn't think his vet sent anything out because it was small and he thought it was a sty. Okay, so based on all of this information, just take a minute and make a problem list for Bluebell. Make sure you consider her whole clinical picture, including her history and her exam, when formulating your answer. Take a few minutes, and when you're done, resume the video. All right, so this was my problem list for Bluebell. So we have a periocular mass that is potentially recurrent after previous surgery. We have a pretty large submandibular ventral cervical mass effect. We have stridor, diarrhea, vomiting, inappetence, hyperthermia or a fever. You don't know if this is truly increased because she may have inflammation or infection, or if she's just excited. And then she's 5% dehydrated. I'm going to go through my problem list, and for the more specific abnormalities, think about my differentials, just so you guys can kind of get a perspective of how I view this case. I think that one of the really nice thing about being on clinics is that working with different clinicians and seeing that everybody approaches cases a little bit differently. Although most clinicians have a really systematic way that they approach formulating a problem list and making differentials, everybody comes to a lot of times the same information a little bit differently. So I just wanted to share my perspective with you so you can see kind of how I approach this and hopefully take something from that. All right, so for my periocular mass, I put neoplasia. I'm a little bit biased, I will say, but the diseases that I feel could cause a dermal mass that looks like this would be certainly a mast cell tumor. That's the most common malignant skin tumor of dogs. We can also see lymphoma cause dermal masses, cutaneous lymphoma, or spread from systemic lymphoma. Plasma cell tumor can certainly cause dermal masses that look like this. Histiocytic sarcoma can cause dermal masses, or sub-Q masses, or internal masses. It can do pretty much anything. Soft tissue sarcoma, common cause for dermal to subcutaneous masses in dogs. Some form of a malignant epithelial tumor, and then a benign epithelial tumor could also cause something that looked like this, but it would be unlikely to regrow after surgery. So we don't know if those are related, but that's why I put it kind of at the bottom of the list. Inflammatory or infectious disease, such as a granulomatous inflammation from a atypical bacterial infection or from a fungal infection, parasitic disease, immune-mediated disease, and metabolic disease. Again, these are going to be less common causes of dermal abnormalities, but I put them on a list because they're certainly still possible and we don't want to forget them. For our submandibular cervical mass effect, I put, again, neoplasia, and I will say that at this point, we don't know if what's going on adjacent to her eye is related to what's going on in her submandibular area. We know that that's a concern, but we haven't proven that those two represent a continuation of the same disease. So for this cervical mass, I put sarcoma, like a soft tissue sarcoma or a hemangiosarcoma. Carcinoma, in this region, the thyroid lives there, and that would be a definite consideration for a large ventral cervical mass effect, although usually those aren't going to grow really quickly in a short period of time. Salivary gland carcinoma, ceruminous carcinoma, or other. And then a round cell neoplasia would be a definite strong consideration because of the quick change over time. So something like lymphoma, mast cell tumor, histiocytic sarcoma, plasma cell tumor, those could all change over a short period. A plasma cell tumor is less likely to cause this subcutaneous, large, firm mass effect, but it's certainly still possible. Inflammatory or infectious disease would be something that I would expect to change over a short period of time to become large quickly. So granulomatous disease is still on the list, and then cellulitis. This would be a really strong consideration for a mass effect in this area because of its proximity to the oral cavity. So penetrating sticks and penetrating bone fragments can carry bacteria, which can abscess under the surface or cause a lot of regional swelling and inflammation before an abscess forms. That would be a pretty big differential for a mass in this area. Vascular would include something like hemorrhage. Also, I would say that that would be relatively unlikely with this history, but you could have, for some reason, a bleed that's slowly accumulating that's not stopping. And immune-mediated disease. I don't know of a specific immune-mediated condition that would result in this off the top of my head, but I haven't ruled it out yet. The stridor, I think, is probably secondary to this cervical mass, causing a partial airway obstruction. And I would say that just because it's gotten worse over the same time period that the mass has progressed in size, but we haven't ruled out something else going on at the back of the throat that's causing a partial airway obstruction or a change in the airway. For our GI signs, I come from an emergency background, and so usually I was taught to think about these in terms of primary GI and then external to the GI when talking about acute gastroenteritis and colitis. So I put on my list dietary indiscretion or toxicity. Again, although Bluebell is watched pretty closely, she's still a dog, and so you can't eliminate the possibility that she put something in her mouth that didn't belong there. Pancreatitis, infectious diseases, parasites, viral, bacterial disease, a foreign body. Again, this is also going to be pretty low on my list because she's not acting like a dog that's completely obstructed, but she could have eaten something that's causing irritation or maybe a partial obstruction. And then neoplasia, like a primary GI tumor. Usually primary GI tumors are going to have more of a slow onset. They can be kind of insidious, causing waxing and waning GI signs that will get worse over a few weeks' time, or they can present acutely due to tumor rupture, but we put it at the bottom of the list. And then external to GI, things that I would be thinking about would be metabolic disease, so renal disease or hepatic disease that's actually having a secondary effect on the gastrointestinal tract. Or we can see things like mast cell tumors cause an effect on the gastrointestinal tract because when they degranulate, they can release really large amounts of histamine, and histamine is responsible for controlling the acidity of the stomach. So when you have lots of histamine, the stomach becomes very acidic. It can cause gastritis, but we can also see it cause gastrointestinal ulceration, which can be subclinical. So they can have frank melena or hematemesis, but they can also just have regular GI signs or no signs at all. Okay, so based on this problem list that we generated for Bluebell, what initial diagnostic plan would you recommend? There's going to be a lot of potential answers here, and there's going to be more than one right answer. So for each test that you recommend, I want to know why you're recommending it for Bluebell in the confines of your practice. What you're looking for with each test, what you're trying to rule out, because you're going to have to justify this to the client too. So take a minute and think about your answers, and when you're done, you can resume the video. Okay, so again, this is my initial diagnostic plan based on my assessment of this case. You guys may have something different, and that doesn't necessarily mean it's wrong. I just wanted to share with you my reasoning behind doing these tests and what I'm looking for so that you can kind of see my perspective on this. So the first thing I think that we should include in our list is a fine needle aspirate of the cervical mass. I really like for masses like this to use the ultrasound to help me get a sample when possible, because some of these masses are going to have more solid components and more fluid-filled components, and I like to actually sample from both. The fluid is helpful because if I end up needing to do a culture, it's going to be a larger sample that I'm going to be able to obtain. From the solid area, I can generally get a better idea of what types of cells are there, which is going to be important in determining our immediate treatment plan. So remember, this patient's presenting to you now, and any samples you send out are going to take at least 24 hours or so to come back. So if you want to try to cater your treatment plan to what's actually going on with that cervical mass, cytology in-house while you're waiting on the send-out stuff is going to be really helpful. If we see intracellular bacteria, then I'll be suspicious of bacterial cellulitis or an abscess, and I would want to start antibiotics. Granulomatous inflammation would push me to test for fungal disease. And then if I'm seeing some wacky cells in the absence of inflammation, I would be more concerned about neoplasia, and all of those are going to have really different treatment plans. I put plus or minus on the periocular mass aspirate here, just because it's going to be really challenging in this awake, excited patient to get an aspirate of that area. If you're sedating her for something else, or if you try and she's actually amenable to it, then great, I would sample it. But I wouldn't necessarily sedate her specifically to get a fine needle aspirate of her eye mass at this stage in the game. Okay, I'm going to do a CBC, which is going to look for an inflammatory leukogram or a left shift. It'll look for evidence of hemorrhage or cytopenias, which may point towards active bleeding or bleeding as the cause of that cervical mass, bleeding into the gastrointestinal tract, or look for potentially evidence of bone marrow involvement for one of her disease processes. And then I'm going to do a chemistry and a urinalysis. This will help me to evaluate electrolytes, which I think is going to be important for her because she's having gastrointestinal signs, she's got poor appetite, she's dehydrated. It's also going to help me look for potentially an underlying metabolic cause of her GI signs or for some of her symptoms. It may help to screen for organ system involvement in some sort of systemic disease process or alert me to concurrent disease that will affect my management plan for her. It will also show me any abnormalities in terms of chemistry values or electrolyte abnormalities that I need to cater my treatment for right now. I would consider doing abdominal radiographs, but I don't think that they're required just because she's having acute gastrointestinal signs. I don't think it's wrong to do thoracic radiographs to look for intrathoracic involvement of this cervical mass that could be extending internally. And then a sedated oropharyngeal exam I think would be really nice and would be helpful for this patient, but it's not something that would be easy to do on a really busy work day otherwise, because this is a patient that I would be very worried about having a challenging intubation. So she has respiratory changes that I'm thinking could be possible to this cervical mass. So I'm already expecting a partial airway obstruction. So if I'm going to do this, I'm going to have to sedate her, know that that could cause apnea, may have to intubate her, and depending on the degree of her airway obstruction, I might need a really small tube or might have significant difficulty actually being able to intubate her. So I want to have more than one person around that can help me, which is not something that's always easy to accomplish in the middle of a work day. It's something where if I couldn't do it today, I would probably include it in the plan for her moving forward or schedule a time where she could come back and have that done pending the other tests. Okay, so you decided to start with this FNA of a cervical mass, and you just did like a really quick diff quick, and we're going to look at those slides right now. So we're seeing here a little bit of blood, and then two what looks like probably round cells. So they have a moderate amount of cytoplasm and a pretty big nucleus. Here we have some more. This one's binucleated, and this one has one nucleus. There's a neutrophil for size comparison. Here's another one, and so you can see that they're exfoliating individually. Again, they have a distinct nucleus. There's a moderate amount of cytoplasm, and you think you see what you're starting to appreciate could be granules in the cytoplasm. So it's kind of hard to tell here because there's some shmoo in the background. But here you can see a few granules, and here they look a little bit more purple in appearance versus pink. These cells are staining a little bit more pink because we didn't leave them in the purple stain long enough. And here's another cell that's kind of molding around a red blood cell, but it's easier to appreciate these distinct purple granules in the cytoplasm. So based on this, I would be concerned for a poorly granulated mast cell tumor. The other round cell tumor that can have a similar appearance would be some form of a monocytic line. However, those don't typically have these purple granules. The plasma cells can also have commonly binucleation, but they also don't typically have these purple granules in the cytoplasm. So I would be, based on this and the absence of other inflammation, concerned about a mast cell tumor if this is the predominant cell that you're seeing. And then we were able to get an aspirate of her periocular mass, and we'll look at that now. So in comparison, this is also a population of round cells, although it's a little bit more challenging to see here because there's so many granules in the cytoplasm. So here's a cell, and you can see the nucleus is still pretty big. There's a moderate amount of cytoplasm, but there's so many purple granules that it's obscuring the borders of the nucleus. And this is what a normal mast cell looks like. You can also see tons of purple granules in the background. Here's another cell. I don't know if it's the same thing. It may be something else that just has granules behind it or on top of it. But if it's the same thing, it looks less well granulated like what we saw in the previous slide. And this is also diff quick, but it's just been stained a lot better so that you can see the colors a lot better. Okay. So right now we're going to take a time machine into the future by a few days so that we can look at the cytology report from Bluebell cervical mass, and we'll go through it together. There's described to be a monomorphic, often large round cells sitting on a light proteinaceous background. They have distinct borders and moderate to abundant blue granular cytoplasm that contains mild amounts to an abundance of fine dark purple metachromatic granules, which is consistent with what we saw, kind of a combination of what we saw on both slides. They describe a pretty good number of eosinophils, which is a common co-finding with mast cell tumors, lots of eosinophilic inflammation. And then free in the background, mild to moderate amounts of fine purple metachromatic granules. Based on this, they're saying that there's a monomorphic population of large round cells with a mastocytic appearance, which in conjunction with a palpable mass would be indicative of a mast cell tumor at this location. Now, I want to point out that where we aspirated this, we just picked a random spot in the mass. Mast cell tumors, they can arise from the subcutaneous space, but for this patient, because we have a mast cell tumor dermally and then a mast cell tumor subcutaneously, and they don't appear to be directly connected, I would be more concerned about metastasis to regional lymph nodes that have kind of gone wild within the lymphatic system and is causing this like coalescing giant mast cell lymph node eating machine. Okay, now let's just take a second to look at her other diagnostics so that we have a good picture of what's going on with her. I also chose to run a CBC, so just take a second to look at that now. You can pause the video. And then I ran a chemistry and a urinalysis. So take a second to look at these. All right. Now, based on the diagnostics that you've done and her history and presentation, what treatment plan would you recommend for Bluebell over the next 2 days? So remember, we're still in the past and we don't have that cytology report back. We just have our suspicion that this is a metastatic mast cell tumor based on what our review of the cytology was. For any medication that you want to give Bluebell, include the doses in mg per kg because you don't have her body weight, the frequency of the medication, and then also give me a brief mechanism of action for each of these drugs. When I approach short-term treatment for a patient, I'm going to be addressing their clinical status. So I'm going to be considering their disease process, but this patient came to you because she was having difficulty breathing, she was having gastrointestinal signs and appetence, and so that's mostly what I'm going to focus my short-term treatment on. For her, that's going to include supportive care measures like fluids. So we know that she's 5% dehydrated, she's having GI signs that are ongoing, she's not eating super well, and she has prerenal azotemia. So even though the creatinine was reported to be within the reference range, in air quotes, remember that for dogs, the IRIS staging identifies azotemia as anything over 1.4, which she was. However, she had really well concentrated urine. So I would say that's probably prerenal. I think IV fluids, either keeping her in the hospital overnight if the owners want to do that, or for a few hours during the day, just to replace her deficit would be great. Subcutaneous fluids are also reasonable since she is eating, and you can try other measures to kind of increase her fluid intake through her food and then monitor her over time to see if that's adequate. I would use replacement crystalloids like LRS, Plasmolite, or Norm-R. I tend to stay away from 0.9% saline except for in specific circumstances. I would choose an antiemetic like Cerenia or ondansetron. Cerenia obviously can, and ondansetron can be given both orally if you decide not to keep her in the hospital, to send her home with some for the next few days. And I would use an antacid. I will just share with you that I don't use an antacid for all acute gastritis or gastroenteritis cases. I know a lot of clinicians will. But I think that for this patient, it would be particularly important because on our differentials list for things that could cause gastroenteritis would be histamine release and production from mast cell tumors. So histamine is very important in mediating the acidity of your stomach. Histamine tells the body to make more gastric acid. And so if you have large amounts of histamine causing gastroenteritis, then we want to try to control the acidity that we think is the mediator in this stomach upset. So we typically are going to choose pantoprazole IV or omeprazole PO, which would be proton pump inhibitors. Even though famotidine theoretically should directly inhibit the histamine receptor, we still find that proton pump inhibitors work clinically better in dogs. So these are the ones that we typically reach for. If you have a dog that does not tolerate PPIs, I don't think it's wrong to use a H2 receptor antagonist, but these would be my first line. And hopefully in doing this, we'll make her tummy feel a lot better. Okay, we also want to add an antihistamine because we think that histamine may be controlling some of the inflammation, potentially contributing to the cervical mass effect and the difficulty breathing, contributing to her gastrointestinal signs. And so we want to block histamine as a way to make her feel better. So for antihistamine, I usually use Benadryl because it's the one that I'm most comfortable with in terms of dosing and for use in mast cell tumors. I don't know, and we don't know how well the other antihistamines are going to work. And so Benadryl is my first line. It also doesn't tend to cause the same degree of drowsiness in dogs that it does in people. And I usually will use a really high dose if I'm worried that a dog is having active clinical signs from histamine release in the body, either a lot of swelling or gastrointestinal upset. So I'll max them out on Benadryl, which is a 4 mg per kg dose, sub-Q, IM, or PO every 8 hours. A lower dose would be appropriate for a dog that's having no symptoms or very, very mild symptoms, and that would be something like 2 mg per kg every 12 hours. So you can go in between there, according to what your clinical presentation is. It's important to note that you can't give Benadryl IV because it can cause seizures. Okay, so hopefully in doing this, we'll block our histamine effects on the body. Even though it doesn't prevent the mast cells from releasing histamine, it may help our patient. The most important thing for any treatment plan is going to be to reassess your patient over time and determine if your effects are adequate. We're going to monitor her appetite, her body weight, and her hydration. And body weight is a good marker of hydration status in the patient, particularly one that you're hospitalizing. Her breathing, her gastrointestinal signs, her overall attitude, and we'll adjust our plan based on how she's responding to our treatment. Okay, now in terms of where do we go from here? So we've stabilized our patient, we've made her feel better. What do we do next? And this is something where you're going to want to talk with your client about referral to a specialty hospital because this is a big, bad mast cell tumor and it's going to require a lot in order to get it under control. So what broad categories of treatments do we have available for mast cell tumors in terms of both local disease, and that would include in this patient the eye masses and the cervical mass, and also systemic disease, so additional spread over time. Or undetected spread to this point. And what steps would you want to take as an oncologist prior to determining the treatment plan for Bluebell? So thankfully, this is a theoretical situation and you do not have to worry about the cost to the client or other client factors when answering this question. I just want you to tell me the possibilities and then in a perfect world, what would you do? So take a minute, think about your answers, write them down, and when you're done, you can resume the video. Okay. So I think that one of the most important jobs for general practitioners in terms of specialty referral, one is to know what options are available so that you can determine when it's appropriate to refer a client. Two is to actually know what those options look like, know what they cost, and be able to prepare clients for what to expect so that in this time where they're really stressed out and really nervous, you're kind of their intermediary or their ally in deciding whether or not to pursue specialty care. And you're also able to prevent referral when ultimately the clients would be obviously very unhappy with that decision. So I think that it's important, not necessarily that you know absolutely how to treat everything from a specialty setting because that would be impossible, but at least the general expectations for what management of diseases may include so that you can kind of have that discussion with clients. Okay, so now as the specialist, we're gonna formulate a plan for Bluebell. And first we need to kind of get to the bottom of all of the factors that are gonna be involved in making a treatment or a diagnostic plan for her. So first in looking at this, I already referenced it before, but this is a bad mast cell tumor. Although the primary mass seems to be pretty tiny, it doesn't matter because the burden of disease is now very large, and we're assuming that this has metastasized to the regional lymph nodes and it's causing a lot of local issues. So that tells me that cure for this patient is pretty much unlikely. And mast cell tumor is a disease process that has a really broad spectrum of possibilities. Some mast cell tumors are really weeny and they may be tiny, may be unchanged for a long period of time. Surgery, even a punch biopsy, could be curative, may never impact patient lifespan or quality of life, versus the other end of the spectrum, which is one like this that came up pretty quickly, metastasized, and is causing clinical signs. Those are ones that are going to be a lot harder to get a handle on. For this patient, no matter what I do, I know that survival is likely to be on the scale of weeks to months, and we have outliers definitely on each end of the spectrum, but this is not something where I'm, telling this client this patient's going to live for a few more years. The other considerations that I want to take into account when I'm deciding a plan for this patient is the stage, and we'll talk about that in a second. The client's wishes, certainly, the cost of treatment and what the client can afford and wants to spend, and then the response to therapy. So certainly if I have a patient that responds really well to treatment, they're going to do better than if we don't see a huge response. And so I'll adjust my treatment plan based on what they're telling me their tumor is susceptible to. Okay, so I want to talk now about local and systemic disease treatment options for mast cell tumors, because you need to know that in order to figure out what plan we do moving forward. So in general, we have surgery to remove disease, radiation to treat non-resectable disease or residual disease after surgery, electrochemotherapy, and this is a really interesting option involving creating an electric field across a tumor and giving IV or intralesional chemotherapy. That electric field is going to essentially porate those cells or punch holes in the cell membrane, which is going to make them preferentially uptake much larger amounts of chemotherapy than, other cells in the body that are just kind of going to be bystanders. So we can see a much larger effect in the area where our electric field is generated. This is a good option for disease that is relatively superficial. So that's kind of nice to keep in mind. For systemic treatment, we have steroids and chemotherapy. So for Bluebell, we have pretty amazing surgical oncologists here, but this is one that, because it feels fixed, I think they're going to be unlikely to be able to completely remove it. The mass by her eye, I think, would be potentially reasonable to consider surgery, but with what's going on in her cervical area, I would rule surgery out for this patient. For electrochemotherapy, the disease needs to be a little bit more superficial than what this is, so I don't think it's a good option. Radiation is a good option to treat the tumor both by her eye and in the cervical area. And then steroids and chemotherapy are still on the table. Okay, so the first thing that I want to know about this patient before recommending a treatment plan is staging. So staging means looking throughout the body to determine where disease is and where spread has occurred, if any. That's going to include for Bluebell thoracic staging, because although we don't typically see mast cell tumors metastasize to the lungs, we could have extension of whatever this thoracic inlet mass is into the thoracic cavity. We could also be looking for big lymph nodes internally that would indicate potential metastasis. We could do a CT scan, and this is something that would be really helpful for evaluating the three-dimensional aspects of this disease. It would also help us to figure out what's going on in her neck. This would be recommended. This would be my recommendation for patients that we're going to consider doing radiation therapy, because I have to do a CT scan in order to plan for radiation in this region anyway. So we could just extend the CT into her chest to make sure we are incorporating all of her disease. If the clients wanted to move a little bit more stepwise or weren't sure if they wanted to pursue radiation, then radiographs would also be reasonable. Abdominal imaging of some sort. Typically for mast cell tumors, we're going to do an abdominal ultrasound to evaluate the liver and the spleen and look for any internally enlarged lymph nodes. A CT would also not be unreasonable. If we're already doing a CT of the head and the chest, depending on where you work and what the kind of system is there, you could consider extending the CT. It may be cost effective. I would definitely, for this patient, sample her liver and spleen. Those are the end-stage organs of metastasis for mast cell tumor in conjunction with the bone marrow. And so there are some patients where we don't routinely sample the liver and spleen. So that would be a patient that has like a teeny tiny mast cell tumor, or one that's been behaving clinically benign that has no documented evidence of metastasis, particularly if the regional draining lymph node is accessible, palpable, and sampleable and is clean. For that patient, I may consider not sampling the liver and spleen. But for this one, we have documented metastasis. We can see that it's causing clinical signs, and we know that this is a bad mast cell tumor. So I would 100% sample the liver and spleen before moving forward. I'm looking for stage 4 mast cell tumor, and that significantly affects our prognosis. So it's reported that patients that have metastasis of mast cell tumor, the spleen, liver, or the bone marrow have a median survival time of about 4 months, but 2 months if they're systemically clinical or sick like Bluebell is. So that is going to put kind of a ticking clock on her care, unfortunately, and that would very likely impact the owner's treatment decisions. Okay, so I'm going to go through the treatment options that I would recommend for Bluebell. There are more than one reasonable treatment protocol, but this is what I would choose. I would choose preferentially palliative radiation therapy combined with Palladia, which is also called toceranib, and prednisone. In one paper looking at dogs that had a mast cell tumor that was non-resectable or that recurred after surgery, the response rate was about 76%. And response is going to include either a complete response, meaning all disease is eliminated from the eye, from being able to detect it, or a partial response, where disease kind of shrinks down and stays there for a period of time. Using this combination of Palladia, prednisone, and radiation, they saw that it was about 51 weeks before the tumors got worse after treatment, which is a good long time. The toxicity of radiation therapy was mild, and that's going to include local tissue irritation within the radiation field, like alopecia, dermatitis. In this case, I would also include tracheitis or potentially some inflammation that could worsen respiratory signs over the short term. Potentially also some mucositis, which might cause dysphagia temporarily. And then just to give you a reference, the cost of radiation therapy, including the CT scan that we have to do for planning at the University of Florida, is $4,500 to $5,000 for this palliative scheme radiation. That does not include Palladia. Just as of, as a point, is this dog's mast cell tumor is probably a lot bigger than most of the dog's tumors in this paper. So if I remember correctly, that kind of median size of tumors in this paper was about 4 centimeters, which is a lot smaller than this. So I would warn the client that my expectation would be that Bluebell would not have as long or as dramatic of a response as what's reported as average in this paper median, because she's not average, she's worse than average. The other option would be Palladia and prednisone alone. So this is going to come with a response rate of about 42%. Again, that includes complete and partial response. The median time to tumor progression on Palladia by itself, and this was for, this paper specifically was looking at dogs that had mast cell tumor that had come back after surgery, either metastatic disease or had regrown. So this is a population very similar to Bluebell. Median time to progression, 16 weeks, much shorter than 51 weeks. Toxicity with Palladia is common. It tends to be predominantly gastrointestinal side effects like diarrhea. A lot of patients will do really well and have this resolve with either a short break of Palladia or a dose reduction. We can also see cytopenias like neutropenia, thrombocytopenia, hypertension, and proteinuria, which we usually manage symptomatically. Less common would be chemistry abnormalities and then myalgia or lameness. The cost of Palladia alone for a dog this size at the vet school would be about $740 a month. This would include the cost of the drug, which is expensive, but also blood work, blood pressure, UPC monitoring, and the cost of the visit. So if we're doing radiation in addition, you have to add these costs together. So it's quite costly to be aggressive for this type of disease. Okay, other options would include vinblastine or lomustine as chemotherapy treatments for mast cell tumor, combinations of all three of these drugs, or 2 out of the 3 usually, or I put in air quotes here, nothing, because nothing isn't really nothing for most clients. It would be something like steroids alone, and then supportive medications like what we talked about before to treat her gastrointestinal signs and block histamine. Okay, if the client elects palliative care for Bluebell with you, what would your plan include? I want you to think about medications, including the mg per kg dose and the frequency for her current status, kind of as she is right now, and a monitoring follow-up plan for her. And I really want you to think about what you will have the client watch for over time to determine if the patient is getting worse. This is a question that I get all the time when we have patients that we're treating for cancer, with palliative disease or with any treatment. The client always wants to know what's going to happen next and what to expect. So it's really important to think about that when you're managing a patient, because your client's going to want to know. Take a few minutes to think about your answer, write them down, and when you're done, resume the video. Okay, and coming up with a palliative care plan for Bluebell, it's going to be relatively similar to coming up with a short-term plan. You make a plan, you institute that plan, and then you monitor the patient. You have to adjust your plan based on how the patient is doing. So I would do steroids for mast cell tumor. The reason why I did not include these in our initial plan before referral was that steroids have an anti-mast cell tumor effect. They can block inflammation within the body, and so we can see improvement of swelling. We can see significant clinical improvement with steroids, but it's a round cell tumor, and so steroids can mask disease or severity of disease. If I am trying to treat a patient for disease as they have it in their body, I want to know how severe it is before I start steroids, and then start steroids as I'm including other treatments and once I've already done my staging tests. So unless the client was rapidly decompensating, and you really don't have another choice, or unless you know that the client is not going to choose referral, I would not choose to start steroids before referring that patient. If you have any questions about whether or not steroids are appropriate, reach out to the oncologist that you would be referring to. They are more than happy to get that patient in quickly so that steroids can be avoided, and also give you guidelines for when to use steroids and what dose and how often, even if they're not referring. I would try really hard to get a definitive diagnosis, and that for me would include the cytology results before starting steroids, even for a patient that I was not going to refer. But again, if you have an acutely decompensating patient and it's life or death, then use steroids. I would use antihistamines, antacids, and other treatments depending on what her clinical status is telling me she needs. So I would treat this just like any other respiratory obstruction. So if you've got like a really hot bulldog or a larpar, the harder they work to breathe, the more swelling is going to ensue, the more stress they get, and the worse their breathing gets. So this is something where I would consider sending home a sedative like trazodone for this patient, just to try to prevent any acute like excitement that could lead to decompensation. I would discuss with the owner avoiding walking outside in the hot part of the day, avoid overexcitation, particularly if they notice that this contributes to worsening of the breathing. I would consider adding gastroprotectants like sucralfate if I had a concern that there was gastrointestinal bleeding at some point. And I would continue antiemetic therapy that we started initially if Bluebell continued to vomit despite our other care, or exhibit signs of nausea despite our other treatments. And then if we're able to control her nausea and she's not eating super well, but her quality of life is otherwise good and the clients want to continue, then an appetite stimulant would be reasonable to try to see if that will improve her appetite. Again, one of the most important things in any treatment plan, acute or long-term, is coming up with an appropriate monitoring plan. So your plan will change as your patient changes. Initially for this patient, I would probably start with every week follow-up. I would maybe even consider follow-up in 48 hours and then back monitoring off as she's clinically improving. It's a good opportunity to discuss quality of life with owners and also to be able to have a conversation with them about the changing clinical status of the patient so that they know what to expect. They know when things are getting worse, they know when things are getting better, and you can give them an idea of time frame for decline in quality of life. This is something that when you have a terminal patient, you know is going to become an issue over the short term. And so I think it really helps people prepare for this if they're able to hear this and have the opportunity to talk about it multiple times over an extended period of time. It's really hard to make a decision to euthanize your pet, you know, same day. But if you have time to kind of adjust and appropriately process information, I think it goes a lot better. And then it's also a really good opportunity to give clients a sign for or symptoms to watch for so that they know what to be on the lookout for to alert you when things are getting worse before they're in emergency mode. It's also, I think, helpful for people to be able to prepare for things so that if something changes suddenly, if they knew that it was possible, it doesn't feel quite so traumatic. So that would be worsening of respiratory signs for bluebell, worsening of gastrointestinal signs, progression of local swelling, lethargy or malaise, and then collapse, either from respiratory failure or from significant histamine release, causing like an anaphylactic type reaction and hypotension and collapse. If she's bleeding into her gastrointestinal tract, she could also develop signs of anemia, which could lead to lethargy or collapse. Okay, so we did it. We managed Bluebell's case, and I hope that you enjoyed going through this with me, even though you couldn't do it in person. I hope that wherever you are and wherever you're watching this, things are okay with you and that you're staying safe.